Now to close this block, we will speak about management of exercise in type 1 diabetes in the era of automated systems. Now I introduce Dr. Michael Riddell. He's professor of the Faculty of Health of the University of York in Toronto, professor in pharmacology and physiology of the University of McMaster, and has performed postdoctoral practices in the Department of Physiology of the University of Toronto. He has published over 250 research articles about exercise, metabolism, and diabetes. His research team is centered around how to make exercise be more safe and efficacious for adults and adolescents living.
It's a real honor. Bruno, thank you also for providing some extra insulin for me last night when I ran out. I'll have more on that story in just a minute. These are my disclosures. Well, I have to let you know that I live with type 1 diabetes, and I'm reasonably active, but I do run into trouble all the time, even though I'm supposed to be one of the world experts on the topic. I use AID systems, and I have for several years, but on the way here, I realized I remembered my passport, I remembered my glucagon, which this inhaled glucagon is a Canadian invention. I remembered my wallet. I remembered everything except a vial of insulin in the fridge to put in my AID system. On the left is a bike ride I did while on an AID system, and a program called Ing8, which was developed by one of my postdoctoral fellows that can visualize the exercise time and range. It integrates with all sorts of glucose sensors and also exercise wearables if you have a watch. Now back to the story of forgetting my insulin. I did have a vial of expired long-acting insulin, and I have been on MDI, well, for a long time. I've been living with type 1 diabetes for 45 years. And you can see that during the run, the beautiful run yesterday, my glucose was trending down. There's no way, if you're not on an AID system or an insulin pump, to lower basal insulin for exercise, which we need to do. It requires more carbohydrate feeding. And the worst was actually overnight, because one of the advantages of an AID system after a day of physical activity is that it can maintain your time and range very effectively by pulling back on insulin delivery. And again, while on Lantus insulin, there's no ability to reduce insulin delivery overnight, and it was a lot of alerts and alarms for me and carbohydrate feeding. But I live another day thanks to a vial of insulin given to me by Bruno, thank you. Just some pictures of some of the early automated insulin delivery system. This system, invented by Dean Kamen, wasn't fully automated, but it was automatically delivering insulin in small amounts as a basal insulin in between meals, and you could bolus, but rather cumbersome for exercise, of course. Since that proof of concept invention, there have been incredible developments over the course of my lifetime of living with type 1. And hats off to Medtronic for having the first commercial AID system available. Since Medtronic's development of 680G and 780G, there have been other players in the field, and some of these players are not available to us in Canada, nor are they available in Chile, but they're available globally. Just a comment about Dean Kamen here. He recently had an FDA approval for a twist pump, which would be another option as an AID system. And I look forward to seeing how this system, which uses the Loop platform, and maybe even an Apple Watch to bolus insulin, might fare during exercise. This is a picture of what Dean looks like now. Maybe one day there'll be glucagon in a pump, and I think that will be beneficial for those of us who exercise a lot and have hypoglycemia. But I worry about the cost and the cumbersomeness of having a dual chamber pump with 2 infusion sets. But certainly early proof of concept studies have shown that adding glucagon for exercise is highly effective in minimizing hypoglycemia. The AID systems that I've tried, and I've tried most of them here, have a similar feature for exercise. They allow the user to raise the exercise target. They differ slightly in what that target is, and they differ slightly in the terminology they use, but they are all very effective in pulling back insulin delivery for aerobic exercise that causes your glucose to drop. None of these systems are doing that automatically, though, and maybe future systems will have a sensor that lets the AID system know that the person is physically moving. But even if it does have a sensor built in, we need to set the exercise target well in advance. And that's one of the key points of today's lecture. Insulin delivery has to be turned down at least an hour before aerobic exercise, or hypoglycemia might still develop, even with these modern AID systems. And that's because when you exercise, your body consumes glucose at such a high rate. In fact, skeletal muscle, when they're contracting, glucose uptake increases 100-fold from rest. No AID system can pull back on insulin enough to overtake this high rate of glucose utilization. If you put someone who's done cross-country skiing into a PET scan, you can see all the muscles that are exercising, including the brain, which is telling the muscles to contract, is using glucose at such a high rate. In fact, we've measured glucose uptake and oxidation to be over 1.3 grams per minute during intense exercise in cross-country skiers, and our bloodstream only holds around 4 to 5 grams in circulation. So hypoglycemia is likely to occur unless we carbohydrate feed and the insulin's almost turned off completely. I don't think any AID system will ever match the complex physiology that's shown here when we exercise. When we exercise, insulin delivery into the portal vein drops precipitously, and that drop in insulin into the portal vein, if you don't have diabetes, tells the liver to break down glycogen at a high rate to match glucose uptake by the working muscle. And at the same time, a person who doesn't have diabetes begins to exercise, glucagon secretion rises. Me living with type 1 diabetes, I have neither of these physiologic effects. My insulin does not drop in the portal circulation, and my glucagon does not rise when I exercise. During other forms of exercise, like intense anaerobic exercise, the catecholamines will rise, and that can increase glucose production by the liver, and some patients will develop hyperglycemia. We even see hyperglycemia in athletes who are not living with diabetes when they do competitive sports, now that we're using CGM on athletes who are not living with diabetes. One of the challenges of being on an AID system is that the insulin absorption rate goes up with exercise. If you think about it, when you exercise, your body is warming up. Blood flow goes to the subcutaneous tissue to help you sweat. And that increased blood flow to the subcutaneous tissue is pulling glucose into the circulation, and it's sending it at a high cardiac output to the muscle, which is then taking up glucose at such a high rate. So unless we change the insulin absorption rate, I think hypoglycemia may always be a threat, even on an AID system. Now, the use of a higher temp target is helpful. In this example here, though, you see that the participant turned on the AID system's higher temp target just when they started exercise. So there was still a large drop in glucose concentration during the bike ride. But nonetheless, the level of glycemic control was reasonable on this system. In this system, in the same type of system, another participant was more proactive. She turned on the higher temp target well in advance of her bike ride, and the system was much more effective in maintaining her euglycemia during the exercise and in recovery. So turning on a higher temp target an hour or 2 hours before exercise really helps the system function better and prevents the need for carbohydrate feeding. Now, because Dr. Wojcicki's here and I respect and admire him so much, I'll share this one slide that shows how effective the Medtronic closed-loop system is on physically active days. These are laboratory studies where participants would come in. We assign them different types of exercise, aerobic, resistance training or mixed exercise. And we can see a very high time in range when the Medtronic closed loop system is used, and very little hypoglycemia. But those are in-clinic studies where we're telling the participant when to set the temp target and to make sure the activity is a few hours after a meal where bolus insulin is given. Now, we see lots of dysglycemia outside of the lab in our active patients. We see lots of hypoglycemia, particularly for the activities that are endurance in nature, aerobic in nature, like a bike ride or a long jog or walk. But other athletes, we see a rise in glucose, particularly if it's a sprint or an explosive activity like a mixed martial arts fight or a sprint, swim, or run. I think that intermittent sports are the best. So individuals who do on-off activities like a soccer game or a football game, where there's bursts of anaerobic activity and aerobic mixed, glucose levels tend to be flatter. And I also see benefits of resistance exercise, which tends to also result in a very flat glycemic response. There are other reasons that seem to aggravate or increase risk for hypo and hyperglycemia here, but these are the general trends associated with the different forms of exercise that our patients are performing outside of the lab. In this one study, it's important to note that although the AID system minimized hypoglycemia, with moderate intensity prolonged exercise shown in blue, you do still see glucose levels drop. And that's in a setting where the AID system was put into a higher temp target 2 hours before exercise, and there was a bit of carbohydrate feeding to make sure the blood sugar was above 120 milligrams per deciliter before exercise starts. So again, the big threat for these systems seems to be aerobic exercise, and it's managing all the other forms of exercise extremely effectively. If you want to learn more about how to manage AID systems, different AID systems in exercise and sport, I'll draw your attention to this article recently published, which was a consensus document on how to best use AID systems for exercise and sport, led by my colleagues Otmar and Desi. But this was several key opinion leaders working together to try to come up with the best guidelines on how to use AID for exercise and sport. And you can take a picture of this QR code if you'd like. All of the images I'll show in the next few slides are available to download for free. Currently only in English, but we hope translation will come soon for these documents. Again, the general types of exercise can predict the glucose response, the typical glucose response. These activities that are aerobic in nature and soon after meals, we see more of a drop. Activities that are mixed, less of a drop in glucose, and activities that are performed during competition stress, intense exercise, we can see glucose levels rise a bit. And this can predict the insulin requirements for those activities and when carbohydrate intake may need to increase in settings where the AID system might not manage the hypoglycemia. What I like about these documents is that they are specific to each of the AID systems that are commercially available. And because Robert is here, I'll show him what the Medtronic system looks like. We have cutouts that allow participants to better prepare for planned exercise, how to set a temp target and when, how to reduce the mealtime insulin if activity is going to occur soon after a meal, and then when to resume the normal target after exercise. And we have nice visuals so that users understand what buttons to push when they use these systems. We also give recommendations on minimal carbohydrate intake requirements when using AID systems in their exercise temp target mode. It's amazing, but you can get away with very little carbohydrate feeding when you use these pumps to their full feature for exercise. Maybe 6 to 18 grams is all you would need for a 1-hour run, which is minimal. That's helping patients maintain better weight control, I think, when they exercise. We also handle spontaneous exercise because we realize some participants aren't thinking ahead 2 hours before they start an activity pattern. So we then also give advice if the activity is unplanned. then the carbohydrate feeding will have to be higher. Again, we've featured several of the commercial systems that are currently available around the globe, and you can use these cutouts maybe in your clinic, but it would be nice if we did translation to Spanish for you, and we plan to. Surprisingly, when we look at large studies in the field, we are not seeing the advantages of closed loop when participants are doing exercise. This large study, which was observational in nature, was over 550 adults with type 1 diabetes doing exercise at home with exercise videos that we sent them. And even though they knew they were doing the exercise videos, they weren't setting their temporary targets in advance of exercise. And you can see that during aerobic exercise in blue, mixed exercise or interval exercise in red, or resistance exercise in green, we were getting about the same drop in blood sugars with the AID system users that we were seeing in standard pump, Robert called it a dumb pump, and also the MDI patients. So I think the potential's there. We just have to work a bit harder on education for patients so that they're setting their temp targets before activity and then minimizing their need for carbohydrates. There are challenges, certainly. It's not automated yet for exercise. Maybe an exercise wearable that integrates with a system could help, and we are doing work with the UVA group with an NIH grant to see if an auto-detected sensor for activity might help pull back on insulin delivery faster. We know that faster insulins would also help, and there are companies that have developed ultra-rapid insulins. And in fact, in one study, we're using AID systems with inhaled insulin. Maybe you don't have inhaled insulin here in Chile, but if you have inhaled insulin, the peak is quick, but the tail is also gone very quickly, and it may be safer to have inhaled insulin at the meal before exercise. And we're starting those studies now with support from the Helmsley Trust. There are lots of individual variation that we can't explain. Some patients just respond differently than others, and some lack consistency within themselves when they exercise, which is challenging. And we know that competition stress can give a very different blood sugar response. You could have a girl doing the exact same thing in practice in basketball, but when she plays a game of basketball, her blood sugars are much different, often much higher. We know that the pre-exercise blood glucose matters, as does the insulin on board, and we know that there is a deterioration in sensor accuracy during exercise. Something about exercise makes the sensor less accurate. It may simply be a lag effect. If you take, for example, a measurement of blood sugar shown in black, so a blood sugar shown in red, you can see the drop in blood sugar is quicker than the sensor drop shown in black. But we can use this information to guide patients on when to consume carbohydrate. So for example, if the person sees the sensor glucose is at 120 milligrams per deciliter, as in this example, their blood sugar is probably more like 100 to 90 milligrams per deciliter. That's when they should consume carbohydrates. They should not wait until hypoglycemia is shown on the sensor, because then they're probably in level 2 hypoglycemia. The carbohydrate consumption needs to be sooner, and we believe the threshold for aerobic exercise is somewhere around 120 to 125 milligrams per deciliter. And just a small amount of carbohydrate, 6 to 15 grams, will do, particularly if the pump is in a higher temp target setting. I wish I had time to share more with you, but in the interest of time, I'll summarize our current knowledge on strategies when using an AID system. If the activity is soon after a meal, you must try to cut the prandial insulin bolus dose. Somewhere around a third of the insulin should be removed. So 33% less insulin at mealtime for activity that occurs soon after meal if it's aerobic activity, like exercise, like walking, jogging, cycling. Set the exercise target well before the start of exercise. 1 to 2 hours is ideal, but setting it at all is something better than nothing. One key factor is not to consume carbohydrates when on an AID system before exercise. This is a habit that's hard for me to break as someone who always would consume carbohydrates a half an hour before exercise to get my glucose up. But when you do that on an AID system, the system will auto-bolus typically. It'll auto-bolus less if the temp target is higher, but it'll still auto-bolus if it predicts the glucose is going over 180. So avoid carbohydrate feeding until the exercise begins, and then you're fine to carbohydrate feed. Pump suspension is okay. Many athletes have to take their pump off for exercise and sport, and that's okay. But typically, the insulin levels still are a little bit high for the first hour of that activity, and some carbohydrates needed. And if the pump is off for too long, they can produce ketones. So we don't recommend taking the pump off for any more than 2 hours for competitive exercise and sport. It's easy to reconnect and give a little bit of insulin, or in some cases, we take a little bit of basal insulin by injection for athletes who take their pump off for several hours, for swimming, for example. And then the last key point I want to reinforce, maybe it's news to you, initiate carbohydrate feeding as soon as the sensor glucose drops below 125. Then you'll be better at preventing hypoglycemia rather than waiting for it to occur. Finally, take a look at this excellent paper that focuses heavily on the work that's been done in the Medtronic 780G and how to best use the 780G pump for exercise. And the graphical abstract has all of the author's key recommendations on how to manage exercise, some of which I did highlight here, including how to avoid carbohydrate feeding before exercise, but initiate it during activity when the glucose drops below 125 milligrams per deciliter. Thank you so much for your attention. I look forward to the question period in case there are some questions for us.
Muchas gracias, doctor, por su
Thank you, Doctor, for that excellent conference.
Vamos a abrir la posibilidad de dos preguntas.
Now we will offer the floor for 2 questions. So if someone wants to ask them in Spanish, Dr. Gracia will be translating into English.
Carola, ¿me escuchan? Sí.
Carola, can you hear me? Yes. Thank you very much for Dr. Villarroel, Riddell. I don't know if he said it or I didn't listen it, but at the end of physical activity, for Dr. Riddell, when do you suspend the temporary objective after finishing exercise?
Muchas gracias. The recommendations first say at the end of exercise to go back to the usual target. However, in situations where nocturnal hypoglycemia becomes an issue after vigorous exercise, we see this a lot in adolescent boys and girls. We can leave the temp target on for 6 hours overnight, and it's very effective if you start to see post-exercise hypoglycemia. Thank you.
¿Alguna otra pregunta?
Hello. Hi, Dr. Michael. Thank you so much for your presentation. As a patient and also as a doctor, what do you think that what must be the gap to be covered for all doctors, because you are in the both sides? So, and apart from that, you have more than 45 years with type 1 diabetes, so you are like the perfect person to talk about it. It's just a general question. Thank you.
Well, first, I just want to congratulate all of you who take care of patients like me and my son, who also has type 1 diabetes. You all are doing such great work, honestly. I cannot be critical of what you do because you have so many things to balance in your busy schedule. What I think needs to happen in the future is that we have more direct-to-patient resources that they can access on exercise self-management. Because we know that most patients aren't doing what we know could help them. And I don't think it's up to clinicians to take 20, 30 minutes to counsel on exercise when they have so many other things to help me with, my lipid levels, my A1C targets, you know, all of the things, my complications. I luckily don't have any, but I think we're moving towards more online resources that physicians feel confident in sending and steering their patients for exercise self-management. And thankfully, we are in that direction. My former postdoc, my former PhD student, Desi Zaharieva, who I think has lectured at this event, is working on a great website out of Stanford. And we are also, with the help from the Helmsley Trust and JABE, developing another website that will be complementary, where patients can learn through video and simulation different scenarios for different exercise events. I think that we can't expect physicians to focus that much on exercise when they've got so many other things to do. But having resources that you could point your patients to, and I think we have to work on translation and global websites that are not just available to Canadians or Americans. And I hope that companies like Medtronic and others who are here could help support that educational resources for active patients, because we know the health benefits of exercise are second to none, and I'll highlight that in another session. Exercise is a powerful medicine, but it's not easy if you're living on insulin. Thank you.
Creo que podríamos quedarnos todo el rato conversando aquí. Lo pasaría
I
muy bien
think
con
that
ellos,
we
pero
could stay here
tenemos el tiempo. Así es que quiero
endlessly.
un
It's so
aplauso para
much fun to talk with, but we need to close, so I want a round of applause for our speakers.
agradecer la organización de este
I would like to
simposio.
thank the organization of this symposium. The
Está
pre-congress is
Ahora
concluding
hay
now.
un box
Now
lunch y
we
después
have a
del
box
simposio de la
lunch and a
industria,
symposium
quiero
of the industry.
salir
So
con
I invite you
retornar para que
to go and
participen de
get your
ese
boxes, but then
simposio.
come
Hay
back
varios
and
simposios,
participate
hay
in that
varias actividades.
symposium. There are several
La
activities.
inauguración oficial comienza en la
The
tarde a las
inauguration
14,
is at 2
Así que a las
p.m., the
14
official
horas,
inauguration.
en
So
punto
at
aquí
2
nos vemos.
p.m. sharp, back here, please. The symposium doesn't have interpretation, we're sorry.